disease management, fibrosis and steatosis, staging with ultrasound, GE ultrasound product leader.
تمام.
الاتش دي ماي عليه ممكن بس نحطه.
اتفضل حضرتك.
البرزنتيشن نفسه مش ظابطه عندي شويه، احنا ظبطناها.
تمام.
بس البرزنتيشن مش ظابطه.
نزل الشي دي طيب بس عشان تقرب اللعبة على
استنى شويه خليني بس. ثواني بس. طيب يلا. Sorry, it's just a technical issue. لا. السلام عليكم. My name is Mohammed Safan and I'm the product leader for GE Ultrasound. I'm dedicated for the general imaging ultrasound. Today it's my first time actually in Egypt. It's my great pleasure. I'll be speaking on one of my favorite topic, which is the advanced ultrasound in liver disease management, with a focus on the liver steatosis and liver fibrosis staging. We will have the first half as a theory, and the second half of the session, it will be a live scan on the ultrasound. So, why the liver? Last couple of years in GE, we've been investing a lot in the liver as a care area to improve our solutions. So 1 billion worldwide have non-alcoholic fatty liver disease. 30% plus out of the worldwide population is infected with the hepatitis B or C. And unfortunately, the liver cancer became the 4th common cause for death. This was as a reason to improve our solution. What we decided to do is 3 points. One, to take the imaging to the next level. We have what we call now next generation imaging, and to empower the system with advanced non-invasive tools and quantification tools for liver fibrosis and liver steatosis. So for imaging, For imaging, we managed to reach to what we call dream in the ultrasound. What was actually impossible physically, we managed to make it in place right away. So with the Illogic E10S, we are able now to reach to 50 centimeter scanning depth and to improve the resolution from the near field to the far field. Whoever used to scan on the ultrasound, the first thing he will look at is the focus point. And what we can see in the cine loop there is no more physical focus point. Why? Because each and every centimeter is in focus. Infinite number of focus points. As a result of this, the uniformity from the near field to the far field is the same. The quality in the mid, far, and near is the same as we usually measure. And with this, we got to scan at higher frame rates. Even if we have the duplex, even if we have the triplex, all this is in place. And this because of a technology called C-Sound image former. What usually happens to our liver? How we move from a normal liver to a life-threatening situation? Viral infection, alcoholic, fatty, type of food, etc. We've been working a lot in the liver fibrosis staging, and there is a technology called 2D shear wave elastography. It's there since some time, and we have improved it a lot. What recently been launched is liver steatosis. And we have now non-invasive tool to stage the steatosis using the ultrasound. Starting with the shear wave elastography. Liver fibrosis was always the golden standard, but with complications. You reach to one target out of 40,000 targets. There is a variability in reading. There is definitely complications sometimes happen with the biopsy. It's expensive, and more important, it's not a tool for follow-up or a tool for screening. Of course, we're not replacing this, but we're trying to expand the practice. With this, the shear wave comes in. And with the launch of any new technology, we look at three important parameters. One is the physics of that technology, then the technique. Third, how we do interpretation. So simply in the shear wave ultrasound, we do have the probe. A signal will come out of the probe to the liver, and there will be propagation. A simple example is how we throw stone into the water, and there will be waves. The faster the propagation, the harder the tissue. That is the parameter. Second will be, what is the technique? The technique is very essential and important to make sure that the shear wave exam is quick, fast, and reliable. Any one of those, if it's not in place, the shear wave exam might take a very long time. So patient needs to be fasting 3 to 4 hours just to make sure that I'm measuring the normal stiffness, not a high stiffness due to higher enzymes level. It's only intercostal approach, and patient needs to be in the supine position. We'll explain this during the live scan. I need to be like 1 to 2 centimeters away from the capsule because capsule is naturally stiff and it doesn't make any sense to measure on or near to it. And to avoid the rib shadows or vessels. For the technique and for the breathing part, I don't ask my patient to take a breath in, or I don't ask him to release. I just ask him to stop breathe as much as he can, and the system will record cine loop as what we will see in the next. So once I have done the shear wave exam, and once I've taken my measurements, as you can see in the picture, those circles are where you can take your measurements. The next step is the interpretation. So I've done my exam, accepted, let's interpret. This table is a result of a white paper where we compared the shear wave values to the golden standard, the liver biopsy. So 0 to 8.29, you're speaking about absent to mild, then 8.29 to 9.4 severe, and so on. So this was what we've done for the shear wave. On the live scan, we will see what we've done to make it even much more easier. The next step, which was very important to treat things earlier, is the cyatosis staging. And what we've done is we've launched the UGAP. UGAP stands for Ultrasound Guided Attenuation Parameter. And same as the shear wave, there is a principle, physics, and there is a technique, and there is an interpretation. So ultrasound guided attenuation, it measures the attenuation of the signal from up to down. The higher the fatty liver, the higher the attenuation. And this will be in values. How it can be measured? Due to two methods. One is attenuation rate, that measures the attenuation over a distance, and the other one is attenuation coefficient that measures the attenuation over distance at a focused or at a fixed frequency. So both are available. It's a preference to which one we use during the scans. This is one of the examples for the U-gap. It's a fixed box at the 4 to 8 centimeter. You cannot take it up, you cannot take it down, because this is the proper place to measure the attenuation from 4 to 8 centimeter. You can take it left, right, depends of course on the needs. Similar concept to the shear wave in the technique, supine position, all what we've mentioned, and accordingly we start to do measurements. There are multiple visualization tools we will see live. One is the quality map, and the other one is the attenuation map. It's a preference, but those are important guidance to help you making sure that I'm doing a measurement at the right place. In shear wave and U-gap, the only learning curve that I have seen is not learning the technique or the interpretation, just making sure the right spot is the right place to do measurement. That will be a learning curve after 20 to 30 cases. And similar story for the attenuation cutoff charts. If I'm following the attenuation rate, you can see the values in the lower line. If you're following the attenuation coefficient, you can see the values in the upper line. According to this, you will figure out the patient is in which steatosis stage exactly. So with this, I'll move to the volunteer and show a quick live scan. I'll take it to them. So again, patient is in supine position, right arm up, sometimes right leg left to open the intercostal space. To me, the difficult patients are not the big ones. The difficult patients in such an exam is the intercostal space, and this is what we try to open as much as possible. Sometimes I can move the patient to the right side as if I'm scanning a kidney and so on, but usually the supine position works well. Of course, the 2D image on the screens is not as the ultrasound, so later whoever wants to see further, we can show on the ultrasound system. So this is the typical view that we usually get for the liver, but I can see lots of vessels and lots of things that can impact my exam. What I do in such a situation, I just go one rib down, I pick elasto, I ask my patient, stop, breathe as much as you can. وقف نفسك. Then I'll ask the system to start, and the system will do multiple shots. The doctor role will come later on to decide which one is good, which one is bad, which one is accepted, which one is not. What if, so with that, I can press freeze. So look at the color here. If the color for me is accepted, I can do the measurement. If the color is not accepted, you can look at the corner here, you can just simply skip the frame. Here, I can just go and pick where I can do the measurement. That was how was the shear wave in the previous systems. What happened here is we have added the quality map. The quality map will help you to see where is the right place or the most reliable place to do your exam. وقف نفسك. Stop. So with this, I have completed my whole exam. I can see on the left side on the quality map that the homogeneity on the higher side is good. And as long as I got 50% filling and homogeneous color, that's good enough. I can do the measurement. It will take me automatically to the next step, and I can do the measurement again. Same story on the other and I move forward. As long as I got 5 consistent values, that's good enough. No need to go for the 10 measurements, and that is validated right away. So once I've done my exam, I've got the places where I have to do the measurement, I look at 2 important parameters. One is the IQR over median. You can see it there in the corner. If it's less than 30%, it means your exam is reliable, accepted. You can go ahead and provide your further diagnosis. And I can see it here less than 6.4%, which means that the exam is reliable. Then, how can I decide this patient is in which stage? If the IQR over median is less than 30%, it means that the median is accepted as a value, as a cutoff value. So the patient value here in kilopascal is 4.5 kilopascal, and in meter per second is 1.23 meter per second. It's your choice to decide which one you want to use. Accordingly, you go to the chart, and based on the range, we can report this. Simply, you can use the worksheet we will show at the end that gives you a comprehensive, complete report for shear wave and U-gap. Let's go to the U-gap. So once I'm done with the shear wave, automatically I can go to the U-gap exam, and I can decide on the visualization map that I need to use. I'll use the color reference map. Again, you cannot go up, down. It's a fixed. I'll ask my patient just to stop breathing. Stop breathing. وقف نفس. Breathe. He was breathing during the scan, but we can see how we will avoid this. So in the first shot, it was quality high. I can accept and move to the next. Same story here. I need to move the box a little bit to the right. Again here. So I managed to do the whole 5 shots quickly, following the right technique and moving forward. I can do more, but as long as the 5 are consistent, we can go ahead. We need to look again at the IQR over median. As long as it's less than 30%, the exam is reliable. Once the exam is reliable, I do accept the median, and I can see it here is 175. As per the chart that we have for the U-gap, we can make our decision forward. And as per the values, patient is normal. He's not even though in steatosis stage 1. So that is the U-gap, that is the shear wave. We understand sometimes the frustration of how long does it take as an exam, but we've seen what we've done for the technology, for the workflow to make it easy so it doesn't interrupt your workflow and add a value. And at the end, if I want to go for the complete report, I can generate a summary report that can show you the fibrosis staging, that can show you the cyatosis staging in one level. And if you have added your own notes on the ultrasound exam, that can be added there as well. So that's all for the shear wave and for the U-gap, fibrosis staging and cyatosis staging. If there is any question, please feel free.
Thank you, Mr. Muhammad. Thanks, my dear colleagues, chairpersons, and dear guest speakers. 5 minutes for discussion. If there are any questions.